profit paper by the title of 70 Gene Signature Prospectively Predicts Prognosis of Patients with Node-Negative Breast Cancer. This is the 5-year follow-up of the RASTER study. I'd like to congratulate Dr. Lin for being selected as, I think, one of the best dozen abstracts of this entire meeting. Congratulations.
Thank you, Mr. Chairman. Mr. Chairman, ladies and gentlemen, it's my pleasure to present to you today, also on behalf of my co-authors, the 5-year follow-up data of the RASTER study. First, the conflict of interest slide. The 70 gene signature has been developed to discern breast cancer patients with a high likelihood of developing distant metastasis within 5 years after diagnosis from patients who remain distant metastasis free for at least 5 years after diagnosis. From the most recent Oxford overview, we know that adjuvant chemotherapy has its most pronounced effect during the first 5 years after diagnosis. The aims of the RASTER study were to assess the feasibility of using the 70 gene signature in community-based settings. In addition, the aim was to assess the effect of the 70 gene signature on adjuvant systemic treatment decisions. Of note, adjuvant systemic treatment decisions at that time were based on the restrictive Dutch national guideline of 2004, the 70 gene signature result, and doctors' and patients' preferences. Lastly, we were of course interested in outcome of this patient group after 5 and 10 years of follow-up. The current aim of the RASTER study is to assess the outcome after 5 years of follow-up. In addition, we asked the following question: what would the risk estimation of the RASTER cohort be with currently used risk estimation tools to guide adjuvant systemic treatment decisions? And for this, we used Adjuvant Online. This slide summarizes the inclusion criteria, which were rather standard. Especially only node-negative patients were allowed, and patients were required to have an operable tumor, unilateral and unifocal. The Dutch guideline of 2004 considered a patient as a high-risk patient when they had node-positive disease, or when they were younger than 66 years old and node-negative, except for patients who had a tumor of 1 centimeter in size or less, grade 1. And patients were considered high risk when they were over 35 years old, were node-negative, and had a tumor larger than 1 centimeter in size, grade 3, or a tumor larger than 2 centimeter in size, grade 2, or a tumor larger than 3 centimeter in size and any grade. To assess risk prediction of the RASTER cohort using currently used prediction tools, we used the Adjuvant Online prediction tool version 8.0. Adjuvant Online is a web-based risk prediction tool that is based on the SEER data and the data from the Oxford overview. It returns 10-year survival estimates based on the standard prognostic factors age, hormone receptor status, histological grade, tumor size, and nodal status. In addition, it estimates the absolute benefit that can be derived from adjuvant hormonal therapy and adjuvant chemotherapy. In this study, we defined low risk as a 10-year survival probability of at least 90%. 427 patients were tested between 2004 and 2006. The median follow-up time was 61.6 months. There were 33 distant disease-free survival events and a distant disease-free survival event was defined as a distant recurrence, death from any cause, or a second primary other than breast. There were 11 deaths, of which 9 were breast cancer specific. This slide shows you the patient characteristics split by the 70 gene signature result. As expected, 70 gene signature high-risk patients were younger. They had more often larger tumors. They had more often hormone receptor negative tumors, and they had more often HER2 positive tumors. Patients that were labeled as high risk according to the 70 gene signature, these were 49% of patients. There were 69% of patients labeled as high risk according to Adjuvant Online. When we would consider Adjuvant Online as the gold standard, then with the 70 gene signature result, almost 30% less patients would be labeled as high risk. The 5-year distant disease-free survival of patients labeled as high risk according to the 70 gene signature was 89.8%. And for the low risk patients according to the 70 gene signature, this was 96.1%. The 5-year distant disease-free survival of high-risk patients according to Adjuvant Online was 92.4%, and for the low-risk patients according to Adjuvant Online, this was 94.4%. This slide shows you the distribution of the 4 risk categories defined by the 70 gene signature and Adjuvant Online. The majority of patients had a concordant high risk, and virtually all of these patients were treated with some form of adjuvant systemic therapy, as depicted by the different colors. Approximately 95 patients were concordant low risk, and almost none of these patients received any form of adjuvant systemic therapy, as seen by the white area of this bar. Interestingly, in the group of 70 gene signature low risk and Adjuvant Online high risk patients, over 50% of patients did not receive any form of adjuvant systemic therapy. And we were especially interested in the outcome of these 2 groups of patients who had not received any form of adjuvant systemic therapy. This Kaplan-Meier graph shows you the outcome of the 2 groups that I just alluded to. The group depicted in the orange line is the group that had a 70 gene signature low risk result and an Adjuvant Online high risk result. And these patients had a 5-year distant disease-free survival of 100%. For the concordant low-risk group who did not receive any form of adjuvant systemic therapy, the outcome was very similar, a very favorable 95% 5 years distant disease-free survival. If we would add patients from the same 2 groups the same 2 groups who had received endocrine therapy only, then the results were comparable. Both groups again had a very favorable 5-year distant disease-free survival outcome. Of course, one would like to know the patient characteristics of this discordant group. And of these 94 patients who were 70 gene signature low risk and Adjuvant Online high risk, and who had not received any form of adjuvant systemic therapy or hormonal therapy only, the majority of these patients was aged between 45 and 55 years. 80% of these patients had a tumor between 1 and 2 centimeters. 82% of the tumors were grade 2. There was a slight enrichment for lobular breast cancers. The overwhelming majority was estrogen receptor positive, 78% was progesterone receptor positive, and 90% was HER2 negative. This brings me to the conclusions. Adjuvant Online high-risk and 70 gene signature low-risk patients who did not receive adjuvant systemic therapy or hormonal therapy only had an excellent 5-year distant disease-free survival of 97.8%. This percentage is unlikely to drop below 90% at 10 years of follow-up. Of this patient group, at least 80% had an estrogen receptor positive, HER2 negative grade 2 tumor of 1 to 2 centimeter in size. And the percentage of high-risk patients could be reduced by almost 30% when the 70 gene signature risk estimation was used next to Adjuvant Online. This brings me to the acknowledgements, and first of all, I would like to acknowledge all the participating patients in this study. In addition, I would like to thank the Dutch Healthcare Insurance Board for financial support of this study, and of course all the research teams in the participating hospitals who made this study a success, and of course the people from Agendia. Thank you for your attention.
Thank you, Dr. Lin, for an excellent presentation, particularly for the, I think at the time it started, really a revolutionary setup of the study, including the fact that the national healthcare system would contribute to doing it, which I think the Netherlands have led the way for many of us. Following on Dan Hayes' comments from before, I think that most of us would agree that it's a relatively easy decision-making in those who are low, as well as in those who are high, but it's about those discordant cases. And you can take two different stances, like Dan said, you know, I'm hesitating in withholding treatment that in principle has been proven effective unless somebody convinces me of the opposite. And the other can say, well, is the benefit, the potential benefit good enough? And now what you show is in that so-called low-risk group, actually patients without any treatment, there must have been 10% of patients who did not receive trastuzumab while being HER2 overexpressing. Some patients with high grade, probably Ki67, 30, 40%. What do you say to those? I'm not among those who would accuse you of undertreating.
Well, Michael Knauer, who's here in the audience, he already studied the HER2 positive patients separately, and he used patients from a large database, patients who had all received the MammaPrint test result. And he showed, and this paper has already been published in the British Journal of Cancer, that when HER2 positive patients have a low-risk MammaPrint result, you can withhold chemotherapy and they will still have an excellent survival. And of course this was retrospective, and here the number of HER2 positive patients in the study is too small to draw any firm conclusions, but yeah, there might be a group of HER2 positive patients.
I think most of us believe that there is actually, despite other rumors, there is a subgroup of HER2 overexpressing patients who actually have excellent prognosis. Just very, very difficult to prospectively identify that. Hopefully MindAct will also address these questions. Further questions from the audience? If this is not the case, thanks again. We conclude the session. Thank to all the speakers and enjoy the meeting.